I'm Dan Mathalon. I'm a professor in the department, and today we are pleased to welcome Dr. Tara Niendam, Associate Professor of Psychiatry at UC Davis and Executive Director of the UC Davis Early Psychosis Programs. Dr. Niendam received her bachelor's degree from Northwestern University and her PhD in clinical psychology from UCLA. She is an expert in neuropsychological and psychological assessment of youth with serious mental illness, particularly psychosis and bipolar disorder. While her research career focused on elucidating factors that contribute to functional outcomes in psychotic illness, Dr. Niendam's recent projects have been focused on developing technologies to improve identification and treatment of individuals with early psychosis. Please join me in welcoming Dr. Tara Niendam.
Good morning, everyone. Thank you for joining us this morning. It's early. It's very early for me. So very excited to be here to talk with you guys about measurement-based care in mental health. I'm going to talk a little bit about my experience, the experience of my colleagues doing this work, particularly in early psychosis populations. So I want to say I don't technically have any disclosures as it relates to the data and things I'm talking about today, but I do have ownership in a technology company, but I won't be talking about that today. So today in this presentation, I'm going to talk about data and how it can inform patient care in general. I'm going to talk more specifically about mHealth technology in mental health care and what the research in early psychosis says so far. And then I'm going to talk about the challenges of implementing it in practice. So there's going to be a little bit of data and science for those folks. There's going to be some clinical stuff for those folks to try to have everyone leave happy. Okay. All right, so how can data inform patient care? How do we use measurement to improve patient outcomes? And so it's a very important point here that data drives measurement-based care. Okay, so what do we mean by measurement-based care? So here's one definition that I particularly like. It's the systematic administration of symptom rating scales and the use of those results to drive clinical decision-making at the level of the individual patient. Well, I want to add one thing into that definition. I want to add and/or collection of data on day-to-day experiences and activities, because that's really what technology can give us, right? And how we use that data to drive clinical decision-making. Why are we even talking about this? Measurement-based care is very big right now in healthcare, and we talk about it a lot as it relates to other clinical issues. We don't talk about it quite as much as it relates to mental health care. But we know in general that we get better client outcomes, providers grow in their skills as a result of using it, and the programs overall can improve in their ability to deliver services and see outcomes. But this is not what we do here in the United States. This is not standard practice in mental health care yet. And the research really shows that part of that is because providers need sufficient motivation, training, and support to implement measurement-based care in treatment. I think all of us who provide clinical service know something new will get thrown at us, and we're like, oh, wait, how do I, and then you kind of do it, or maybe you don't do it, or maybe you just forget about it, because we need the support to be able to implement it appropriately in care. So that's a big challenge for our field. Here's some data. How many of you look at this and get really excited? About half the room. Yeah, there's we can get some binary in there. Oh, we got a spreadsheet. How many of you look at this and go, ugh. Thank you for your honesty. Okay, so these are data, and I think most people, at least when I'm out talking, I go out and I work in community practices all the time, and I talk about data, and this is what they all think. They're like, oh, spreadsheet. Well, that's not really what we need to talk about. Sorry for those of you who got really excited. But that's not what we have to mean by data. So let's talk about data in a different way. Let's broaden our data horizons. So what are data as it relates to mental health care? Well, the first definition gave you validated symptom measures. The PHQ-9, great example, validated symptom measure. We could also think about validated behavioral measures. We could measure behaviors. And then it really can be any data that's relevant to the person that you're working with. You know, what is relevant to them and their treatment goals? What are they trying to change? That can be your data. So we can use data in 3 different ways in mental health care. We can use it to generate a hypothesis. And we can think of it, you know, small data, that's N of 1, individual level data, and that's mostly what I'm going to talk about today. There's also a big emphasis right now on big data, so that is many data points across many individuals that you can mine and find patterns in. I'll talk a little bit about that today, but not at the big scale. We can use it to test that hypothesis, and we can use it to track treatment progress. So one really important point I want to make is for those of us here who are clinicians, data doesn't care about your theoretical orientation, because I will own I am a CBT and family systems person. Thank you, and I'm sorry. I feel like I have to say both of those. So, and most of the time people look at me and be like, oh, well, you do CBT, so that's why you like. I don't do CBT, so I don't like data. Well, let's really try to shed our theoretical orientations for a minute and just all agree that we want our patients to get better. So really data, we can think of it as independent from theoretical practice. And so whatever intervention choices you are making, you can use data to create measurable change. Okay, so everyone just try to put your theoretical orientation aside and think, how can I use information in a systematic fashion to support change in my clients? So let's, I'm primarily a psychosis person, so most of my examples are going to focus on that. So let's talk about generating a hypothesis. So this is a great example of someone from our clinic. Sam is a 25-year-old male who uses cannabis regularly and is somewhat motivated to stop, but doesn't know how. So as the clinician, you say, why do you think you use, Sam? Sam, I guess it relaxes me. The clinician says, are there times when you're more likely to want to use cannabis? And so really, from a CBT or DBT perspective, you're not triggered. Sam says, Clinician, let's collect some data. Okay, so then the next week you say, okay, Sam, I want you to write down what you did and what your desire to use is. So this isn't a validated scale. This is from 0 to 10, right? Very simple. Let's look at what you did, and let's look at your desire to use. Do you guys notice any patterns in this data that might help you generate a hypothesis? This is where it gets interactive, folks. Yes? Okay. Pleasant activities, getting something done, feeling engaged and motivated, less desire to use. What else do you notice? Using it when he's stressed out or in a fight. So great. We have this one, big fight, dinner with parents, wants to use a lot. Oh, I'm bored. And being bored can be stressful, right? That's a hard thing sometimes for folks to manage. High desire to use. And then here, he left early. Maybe that was a stressful social situation. High desire to use. So we've got a hypothesis here that maybe it's these stressful situations that drive his ability to use. So that is some data that you can then use to say, what if we can put some other coping behaviors or whatever it may be from your orientation to manage stress in a more efficient and effective way to decrease use. That's one example of how we can use data. Now let's test a hypothesis. Aaliyah is an 18-year-old female with severe negative symptoms of schizophrenia, including anhedonia and avolition. So that sort of lack of motivation for social engagement, goal-directed behavior. Clinician says, what do you like to do for fun? Aaliyah, nothing's fun. There's no point. Have you ever heard of the anhedonia paradox? She's like, no. So then you tell her about the anhedonia paradox and say that it's really about prediction of fun, right? And the difficulty kind of predicting what you're going to want to do. So you're less motivated to do it, but you'll, in the moment, have fun. And then the clinician suggests that we collect some data to test this hypothesis. So, unicorns. The clinician knows that Aaliyah likes card games and likes unicorns. Who doesn't like unicorns, right? So they suggest that you don't like unicorns? Shame. Okay, you can pick any card game. On a scale of 1 to 10, how much do you think, Aaliyah, you would enjoy playing this unicorn card game next week in session? So the clinician's asking for that prediction. How much do you think you're going to enjoy it? And Aaliyah's like, a 2 out of 10? Doesn't look and sound like therapy to me. We get that all the time. So then the next week, they play the card game. And it's an awesome card game. Aaliyah, how much are you enjoying this card game right now on a scale of 1 to 10? 6 out of 10, it's okay. And then the clinician reminds her that last week it was only a 2 out of 10. And so uses this as a motivator for behavioral activation. That sort of just do it, let's get out and try something. You will enjoy it if you do it. If you try to predict how much you're going to do it, you're going to be less likely to try. Okay? All right. Example 3, tracking treatment progress. May is a 22-year-old non-binary individual with a diagnosis of schizophrenia. They have been stable in treatment, experiencing minimal to no symptoms for the past 12 months. May wants to reduce their antipsychotic medication because the side effects are bothering them. So the MD proposes they slowly titrate the dose while tracking symptoms to check for relapse. Okay? So here is an example of some data that you would get from one of the apps that we use. And you can look over the course of the weeks and see how symptoms get worse. So the dark pink is voices, the light pink is suspicious thoughts, and the teal is energy level. And this energy level is the thing that May wants to increase. So we can see we titrate the dose down. Things are looking pretty good. Week 1, 2, 3. Oh, energy goes up. May is like, yes, this is what I'm looking for. I feel good. We get out to week 6, 7, and 8, and we start to see those positive symptoms coming back in. And this data really helps May to see that their symptoms are being managed well by the medications. And then there's a choice point. How much is this increase in energy worth this increase in symptoms? And then you're able to engage that client in shared decision-making about medication. Okay. So these are just trying to motivate everybody for data. Okay. So now let's switch to mobile health technology, because all of the examples I just gave you are things that you can do with a pencil and a piece of paper in your office. Okay? So let's talk about mobile health technology. I think we're all now in agreement that everything is in our smartphone, and soon our smartphone will be embedded in our arm, and we'll be able to levitate. It'll be amazing. But for right now, what does it mean in mental health care? And what does the research tell us so far? So this is the area that my colleague Laura Tully and I have been focusing in for the past couple of years, and really trying to understand how this explosion of apps and web-based platforms can be used to help people see how they're doing, understand how they're doing, and improve their outcomes. So I want to be clear, I am not going to discuss the entirety of data in the mHealth space right now. I'm going to focus on the work we've been doing in early psychosis at UC Davis. And we've really been trying to address one big problem, and that's relapse. So for those of us who work in populations like bipolar disorder, schizophrenia, serious mental illness, we know that relapse is the thing that we are trying to prevent. So in community settings, about 80% of individuals with psychosis will relapse within 3 years. Even with early psychosis programs like the program here at UC Davis, or at UCSF, the one we have at UC Davis, we will still see relapse in about a quarter to a half of the individuals after their first psychotic episode. And this is costly. It's costly in terms of money. It's also costly in terms of stress on our patients, on their families. It's a big deal. So it's a really important area to try to address. So the goal of what we've tried to do in our work is focus on improving the client and provider interaction, to provide data to both the client and their provider so that we can monitor and intervene before relapse happens. That's the goal of the work that we're doing. So in our app, we have the client-facing app where they input information, and then all of that gets populated to a provider-facing dashboard that is designed to be shared with the client. It's not just for us. It's designed to, you sit there and you do shared decision-making. All right, so within the app, this is what the old version looks like. It looks a little different now. There's daily surveys where we ask questions like, how was your mood? Did you take your medication? Did you hang out with anybody? Did you have any social conflicts? If you did, how upsetting was it? Again, trying to get those stressful triggers that we talked about in one of our examples. And then each week, we have a more detailed assessment of psychotic-like symptoms and anxiety and depression. So they rate these on a Likert scale, as well as sleep and medication adherence. So I'm going to talk about two different studies that we've done. The first one, the question we were trying to answer is, can we integrate an mHealth platform into outpatient care? Is this even feasible? When we started doing this work 4 years ago, everybody was like, folks with psychosis are not going to let you put stuff on their phone. They're just not going to do it. We were like, we think they will. So we decided to try. Will they be willing to use an app that tracks behavior? Will they complete surveys? Will survey completion be related to the symptom severity? So for folks who are more ill, will we get less data? Okay. So in our study one, we did this at our early psychosis programs at UC Davis, which are housed in our Department of Psychiatry. We have 2 clinics. We have EDAP, which is self-pay or insurance, serving individuals 12 to 40 who have early psychosis. So they have fully psychotic symptoms. We don't really worry about which diagnosis, so it could be affective or non-affective psychosis, as well as individuals at clinical high risk. So they're showing those attenuated clinical symptoms that put them at higher risk for developing psychosis later. We also have our SAC EDAPT clinic that is Sacramento County funded with Medi-Cal dollars. It serves individuals 12 to 30, same diagnoses. So this is where we decided to try this out. We had the smartphone app I described and the provider web-based dashboard. So at the time we were using Ginger.io, which some of you may have heard of here in the Bay. They've left this space and are doing something a little bit different. So we had our participants complete daily and weekly surveys via the app, and then we brought them in each month. And we did gold standard research evaluations. We did the BPRS, Global Functioning Social and Role Scales, because we were checking the validity of those self-report measures. And we followed them up to 14 months. We had, at the time, 143 individuals in our program. We enrolled half of them in the study for up to 14 months. You can see that there was a group of individuals who didn't do any research, so it wasn't just about our research. Only 15% didn't like the smartphone tracking idea. So it was actually a pretty small proportion that were concerned about the technology, okay? So in terms of the results for feasibility, on average, folks were there for 183 days. This was not related to their symptom severity, so we didn't have the more ill folks drop out. They stayed in the study just as long as everybody else. And we saw pretty high rates of average survey completion, 77% of the weekly surveys and almost 70% of the daily surveys. People did a lot of surveys. And survey completion wasn't related to their symptoms or their time in the study. So to us, this was like, this is feasible. We can do this. We can collect this data. The next question we wanted to answer is the validity question. Can we collect valid data from a smartphone? Is it going to be comparable to what we would rate on one of these gold standard measures? And what we saw, so we had about 70% of people who contributed to this analysis. We had a couple of people who had issues that we had to withdraw. And what we saw is that there was a relationship between self-reported and clinician-rated positive symptoms. So those self-report items were capturing what we were seeing as clinicians. We also saw the same thing with depression and anxiety. So we were collecting good data. Negative symptoms, there was no association. We've thought about this a lot. We think it's because the BPRS actually isn't the best measure of negative symptoms, one. And then two, it requires folks to have a lot of insight into their negative symptoms, which folks often don't. So gathering negative symptoms with smartphones requires some tweaking. Okay. Now, can we predict symptoms getting worse? So this is some of our preliminary data that we're preparing right now. Can we use these weekly self-report symptoms to predict someone getting sicker at month end? And what we tend to see is yes. So we see that an increase in depression predicts an increase in positive symptoms. So these are all individual people, and there are multiple data points. And so you can see the trajectory. We see a positive relationship there. We see it. The black line right here is that group average. You see the same thing for anxiety and positive symptoms, and then visual perceptual abnormalities reported on the smartphone are related to clinician-rated positive symptoms 1 week later. So it is able to capture those subtle changes that we're trying to see to intervene and prevent relapse. Okay. So in our next study, we wanted to know, okay, great. Now, we just did this in a university-run clinic, which is a tightly controlled environment. And we paid people. We paid people to do the surveys. We paid people to come in for research assessments. That is not the real world. So this is that problem of taking research, setting, interventions, and trying to take them to community, right? We often see things fail in this transition. So our next study was, can we take it into community? And will they engage without the infrastructure, without the money? Will providers integrate the dashboard into their care? And what does it cost to do this? Because if I were to approach any of you who has a clinic and say, hey, I have this great app, you'd be like, how much does it cost and what is it going to get me? So that was the question we were trying to answer in this study. So here we expanded to 2 additional EP clinics in Northern California. So we have partnerships in Napa and Solano County. They serve pretty much the same population. Napa goes a little bit younger. We didn't enroll kids that young in the study. So we took it out into the community. We had an app and a provider web-based dashboard. This time we used life data. I don't know if any of you guys have experience with life data. It's an ecological momentary assessment app. We tweaked it a little bit for this purpose. So they completed surveys, no money, for up to 5 months. We only did clinical assessments at baseline and study end. That was it. So how does it do in the real world? We also asked the EP providers at the clinic to complete weekly surveys regarding its use and its impact on care. We had 108 eligible folks at the 4 sites. Again, about half enrolled in the study. Here's the spread across the clinics. I have to say Napa is a much smaller clinic, so that's why the numbers are lower. There are the dropouts. So we had 67% complete that 5-month study. Average time in study was 156 days. This went down. We weren't surprised. So we had lower response rates to the daily and weekly surveys. And we did see here that higher negative symptoms at baseline were associated with lower weekly survey completion. All right, provider adoption. We had 20 providers across the clinics, 4 MDs and 16 therapists. The therapists mostly had master's level degrees. The majority of them were licensed. Each of them had about 6.5. How you have half a client, I don't know, but that's the mean. A range of clients that were enrolled in the study. The therapists were asked to complete the weekly surveys regarding the dashboard use. 12 of them completed at least 1 survey. They tended to see about 2 enrolled clients per week. And on average, they incorporated it into 1 session per week. And I'll be honest, we didn't give them a lot of support or training in doing this. So this was sort of, what would you do with this on your own? They tended to discuss it for about 10 minutes of a 15-minute visit. And they rated it, when they used it, they rated it as moderately useful. At the end of the study, 85% of them said, I would use this again. And we do get regular requests from these providers to bring the app back. So in general, they used it. When they used it, they thought it was useful. Again, they didn't have a lot of training or support to integrate this into their practice. Okay. So if we were to go outside of my app work and talk about a little bit more what's happening in the EP space, we see there's other developed projects. We have a collaboration with UCSF to reduce the duration of untreated psychosis in Sacramento County, and that is a tablet-based screening that we are doing currently at 31 sites in Sacramento County to catch and refer individuals with early signs of psychosis to our early psychosis care. So that's one project. Prime is a smartphone and web-based peer-to-peer app that was developed by Danielle Schlosser. And let's see, MOST is another peer-to-peer intervention group. Heal Your Mind uses cognitive behavioral case management, symptom management. WellWave is another one that's really worked to have some preliminary efficacy data to show that it boosts physical activity and improves relationships with clinic staff. So these are some other ones that have some preliminary support in early psychosis care. Okay. So some caveats to this. I've shown you a lot of data. I've tried to really sell you on this. But now let's talk about why we should proceed with caution. So most of the current studies have focused on feasibility and acceptability. Very little data on efficacy has been published in peer-reviewed journal articles at this stage. And that's important because in that critical review, you're really challenged to think about your data and what you're presenting. Studies are typically very small, 20, 30 people, and usually over a very short period of time, sort of like a drug study, very short in terms of efficacy, 1 to 3 months. So that's why for us we pushed it as far as we could. We wanted to really see in the long, because if we were going to use it, we wouldn't use it in clinical practice for 1 month. We'd want to be using it in the long term. So we wanted to see that data. So, really proceed with caution as you see these apps pop up or, get the emails trying to sell you something. It's important to be a cautious consumer. So if you want to use technology, I just told you how awesome it is. How do you think about that? Read the research literature. That's probably, honestly, the best way to start. Go to PubMed, put in the app that you're interested in, and see what comes up, if anything. Again, and some of these apps that are being developed in the tech space, you won't find studies. They won't have published anything. They'll have data driven by a company. Okay? Carefully read the EULA, the End User License Agreement. Does anybody read those when you guys download an app? Does anybody click on that link to please read? Right. Has anyone ever done it? If you did, you would see all of the legalese that comes up. There's a lot there to read and to understand. So if you're going to recommend it to your patients, please read what that app will do with their data. Think about that. Think about it for yourself. Would you want your data used that way before you recommend it? Because remember, as you recommend it, you're giving it oomph for them to use it. And then try it yourself. Some of them are very clunky and are hard to read or hard to interpret. So if you're using it and you're like, oh, this is so annoying, I'm going to bet you $100 your clients aren't going to like it either. So please use it yourself. Additionally, you can look at this wonderful website that has been sponsored by OneMind. It's called CyberGuide. It rates every app on credibility. They read the literature for you and tell you how credible the findings are. They assess the design, accessibility of it, and then they look at the privacy policy, the data storage, so that those security features will tell you how well an app is doing. So I encourage everyone to use this. All right, so some challenges that we noticed doing this work in practice, and I think this is helpful for you guys to sort of think about as you might decide to bring technology into your clinical space. Provider engagement, implementation logistics, costs, and ethics. So, provider engagement, you gotta have buy-in. I started this talk by just trying to get you guys to believe data was useful. You know, that is really a foundational belief that one has to have before you engage with this. And so if you have providers that don't believe in data, you really have to start at that very basic level and understand what is it that they want to know or learn from their clients, from the data, and how could this technology facilitate that. Their comfort with technology. I mean, some of us have grown up with these things, but there's folks who haven't or who don't have access to them. And so we may be fine using 1,000 Fitbits and whatnots and all sorts of things to track our every move, but there's a whole group of folks who are not, and there's many providers who are not. And so to really be mindful of that and their knowledge and their comfort. And then workflow and time management. This is the biggest consideration. We all work, we do a bajillion things in a tiny amount of time. And so if the tech doesn't save them 10 minutes, they don't want to use it. You know, even if you could save them 2 minutes, they might consider that. But you're really trying to save them time, increase their efficiency. So you have to think about workflow and time management. Implementation logistics. Technical glitches. One of the concerns we had with our second study in the use of live data was we had a lot of technical glitches. And so were the response rates about the study, about the app, about the data we were asking about, or was it really just about the fact that they kept getting locked out of the app and were losing their minds? We hypothesized it was more about the second thing. So there were multiple technical issues that we had. And we've all used bad apps. You just stop using it. So, and that's what your clients or your providers will do. So making sure that you have staff support to support your clients and your providers in using it. Incorporation into workflow, making sure they have very easy access to the dashboard. The biggest piece of feedback we've gotten is from providers is now I have to open another page. So they've got their medical record open, they've got our thing open, they have their email open, then they're having to toggle back and forth. That's set shifting. That's a lot of cognitive demand you're putting on a person, so they want it all integrated. So that's one of the things we're working on. Implementation costs. So this is some of our published data. Smartphones as part of treatment. We found that about half of our clients did not have a compatible smartphone. And all of us are like, wow, that's interesting. I didn't know that. You think everyone has them. No, they actually don't. So you have to be ready to pay for it. So you got to be willing to buy a phone and pay for a line. I've been asked by multiple people, is having a cell phone an intervention? I'm like, yes, it is. It means we can reach you. That's important. So honestly, it'll make your clinical work easier in general to just make sure your folks have a phone. So for a person, it's about $1,300 for 2 years. One person. And one of the other pieces we've realized over time, this is the cheapest phone we could get. Those phones become disposable, so then you have to think about buying more expensive phones so you can use it with other people. So, staffing support. It took us a half-time person to keep that study running. Taking phone calls about phones that weren't working, or I lost my charger, or whatever it may be. Clinicians couldn't log in. Oh, let me go over to the clinic and help you log in. They couldn't read the data graphs. Let me teach you about the data graph. So you really do have to have technical assistance. We get used to doing these things on our own, but in this sort of field, it doesn't work very well. The idea here, for those of us who do this work, is that we're going to offset costs. So by giving someone a phone, $1,300 phone for 2 years, we're going to avoid that $14,000 hospitalization. But we really need to show this data, these sort of cost-effectiveness data, and nobody's really gotten to this point yet. Ethical considerations. Informed consent, privacy, responsible data use. So I think we all know now how our privacy has been infringed upon by some of our most favorite applications. It's caused a lot of press, a lot of concern, right? So I think in this area, as someone who talks about using data and talks about using applications, we think this is a very important issue for us to discuss. So again, those EULAs that you get are dense legalese, and really they are about protecting the company. They are not about protecting you or your patient. Okay? There's stuff in there about what they will use your data for, how long the data is theirs, and they consider it theirs, and they sell it. That's a big part of how they make money. So this is really problematic for those of us who work in sensitive populations. Okay? And so when we're working with somebody and we're trying to say that, oh, this app is going to track your sleep and where you are and how far you walk and where you go, the first question I get is, do you know where I live? Technically, yes. But sometimes that gets hidden in how we pitch it, right? So, we really feel strongly that, in terms of informed consent, that having a EULA on an app when you're working in the sensitive population isn't enough. You really need to check for understanding. And at the beginning, like you would in an assent for a child, I'm not saying our clients are like children, but have that language broken down so that they are agreeing to the very specific things. They understand what data is being collected. They understand how long it's going to be used for. They understand where it's going to go. Those really important pieces. And if they say no, to respect their no. Because I think most of us would have said no to some of the things that happen to our data. Okay. So that's the informed consent, really respecting people's privacy, thinking about, do you want that data collected on you? And then when you have the data, what do you do with it? Do you give it to other people? Do you put it up on a data repository for anybody to mine? To think about where that end spot is going to be and make sure you get consent for those things. So in this area, Dr. Tully and I feel very strongly that we need to have the highest standards. We need to be very thoughtful about these things. Those comprehension checks for the EULA, explicit agreement options for data sharing. Are they willing to give you the data for the study but not share it widely? And then making sure that your treatment isn't contingent on using the tech. All right. So in summary, I've shown you that we can integrate mHealth into EP care. It's feasible even when you don't pay folks. That self-report data that we get using the technology is valid and does predict symptom exacerbation. Both clients and providers think it's useful and are willing to use it. The barriers to adoption are there, but they're addressable if we're mindful. We really need to do that cost-benefit work to justify to large health systems that this is worth adopting. And we really need to think about ethics when we're choosing our technology and implementing it. Okay, so this work takes a large team of individuals. I really want to acknowledge Laura Tully's work in this area, as well as our biostatistician, Maria Yosef, had a number of different funding streams for this, and our mobile tech partners. There's a bunch of citations here as well. So that's it.